Good
Good
morning,
evening.
everyone.
Okay. Good evening, everyone. Welcome to tonight's webinar and podcast, Global Health Futures, Scanning the Horizon for Emerging Risks and Opportunities. We have three very experienced speakers from the health sector who have global perspectives. And we will look at global health risks from two angles. One is from within the sector itself, so intrinsically health-related risks such as pandemics, but also from the other side, from the side of other existential risks such as climate change, AI, and so on. So they are we look at it from both sides, and that is because at Extra we have our main analytical approach is to think of existential risks as part of a polycrisis. That is, different risks interact or they simultaneously affect the system on which our survival depends and thereby may endanger it without necessarily directly interacting. So that's our approach. We like to look at existential risks from a holistic perspective. All right. So while good health and well-being has been a top priority in the UN's 2030 agenda, it's the SDG number 3, we are not meeting the targets that were set at the time. And according to the WHO's recent World Health Statistics report, we're quite far away. And their director, Tedros Ghebreyesus, notes successes are uneven across regions, and health systems are increasingly vulnerable to systemic shocks. And those systemic shocks, of course, come from other existential risks. Progress has stalled, for example, on the reduction in mortality due to non-communicable diseases, which is still the main cause of death globally. Meanwhile, we've had 22 million excess deaths on account of the COVID-19 pandemic, and that has wiped out a decade of gains in life expectancy. So this comes at a time when also global development assistance for health has plummeted, led by the cuts in US aid, but unfortunately other countries have not filled the gap, but have rather followed the example and have cut their aid. And that has consequences for health on a global level. For example, access to medicines for diseases such as HIV and to vaccines is becoming more difficult in some parts of the world that have relied on that aid. Um, there's also been a recent statement by Project Hope that warned also of growing vaccination gaps and outbreak risks and increased antimicrobial resistance. And there's also other issues that are becoming increasingly concerning, such as the mental health epidemic and a crisis in the health workforce, a lack of health workers, especially also in aged care. Now, against the uh, this backdrop, we'll be talking to our experts about their own experience and see what they can, how they can enlighten us about the state of affairs. And I'm handing now over to my colleague, Anna Maria Parache, who will introduce the speakers.
Thank
Anna.
you so much, Thomas, for the introduction and for everything. So, to explore these questions, these challenges, we have today three world-class experts joining from around the world. So, I will start with Professor Andrew Haynes, who will bring us perspective on climate change and planetary health. He's a professor of environmental change and public health at the London School of Hygiene and Tropical Medicine, and one of the founders of the planetary health concept. He has worked closely with IPCC, a major international health initiative. And in 2022, He received the prize Tyler for Environment Achievement. Alongside with him, we have also joined us today my dear friend Dr. Nabil Goer, who brings a perspective from global health system and strategy. He's a PAT, is a PAT chief of the Asia, Middle East, Europe region, actually all the across the world. And previous, he was working also, had senior roles with the Commonwealth Secretariat, working with ILO, with the World Bank, with UNDP, USAID, and government of Pakistan. Dr. Goher, thank you for being here. And completing our panel, we have Professor Stefan Brunkenberg, I hope I pronounce very well, joining us with a perspective from psychiatry, social medicine, risk analysis, and he is a medical director of teaching hospital in Dresden and Salzburg, chief physician in psychiatry, and holds a chair sustainability and social medicine at MITA University of Applied Science. He's also trustee of the World Academy of Arts and Science and member of Club of Rome. And I also want to add that our moderator and the chair of Extra, Professor Thomas Rutter, has spent the past decade research for food system and sustainability and has held leadership roles in World Academy of Arts and Science, International Science Council, Future World, Future Earth, and World Anthropology Union. So actually we have three outstanding experts plus our moderator with us today, which will bring a different perspective on this conversation. Thomas, the floor is yours.
Thank you, Anna, for your kind introduction. And I will, first of all, ask each of the speakers about their work experience, beginning with you, Andrew. If you could give us just an idea of how your work experience has shaped your perception of global health risks. How, from what side do you come to this topic? And also, what are the most pressing and risks in your view, and the ones we are least prepared for? And feel free to share your screen if you want to show us some visual information.
Well, just a couple of words about my own background. I mean, for many years I was a practicing clinician, trained in, initially in internal medicine, but actually went into family medicine because I enjoyed working in the community and working with a very diverse range of people. And spent many years in clinical practice, also as an academic, as a professor at University College London. But then about 25 years ago, I moved to the London School of Hygiene and Tropical Medicine, where I had a role as director for over 10 years. That's a very multidisciplinary institution, which doesn't just focus on tropical medicine. The name is a very old-fashioned one. It really covers a whole range of global health topics. And I first became interested in the whole concept of climate change in health, I guess, in the late probably about early 1990s, actually, when I started to hear about this concept of climate change. And I'd worked in very diverse situations, diverse climates, diverse countries, and I'd seen different types of disease. So I knew that climate change would affect human health, but at that time, no one was writing about it. So I started to write in a rather kind of speculative way about this topic. And initially, nobody was really interested, but I was contacted by the late, great Tony McMichael, who, of course, used to work who was Australian, as a great thinker, who wrote really one of the first books on planetary health called Planetary Overload, which was very, very prescient book, wrote it nearly over 25 years ago, and really, he foretold really what's happening now. And through him, I collaborated a lot, worked on the Intergovernmental Panel on Climate Change, as we've already heard. And then as I stepped down as director at the London School, I was able to continue and develop and strengthen the work on climate change and planetary health. And in 2014, I was asked by Richard Horton, the editor of The Lancet, to chair the Rockefeller Lancet Commission on Planetary Health, which is specifically tasked with looking at the interlinkages between the health of the planet and the health of the people that live on the planet. And so that was a very interesting challenge. And we did a lot of work in a very short time, trying to articulate this kind of concept of how the health of people was linked to the health of the planet. So let me just show one or two slides just to kind of summarize what I think is quite a complex concept. And it looks like I'm being blocked from sharing. So if you could give me the ability to share, that would be helpful.
Okay. Harini, would you please enable sharing for Andrew?
If that's a problem, I can just...
It shouldn't be. Okay, hold on. Okay.
Well, look, while we're waiting, let me start by saying that thanks to work of people like Johan Rockström and many others, this concept of planetary boundaries has been developed, which are really the kind of finite boundaries within which we have to live as a civilization on our small planet. And if you look back in 2009, I think it was, they thought there were seven. They proposed 7 planetary boundaries, of which 3 had already been transgressed. And moving that forward to 2025, they're now proposing 9 planetary boundaries, including pollutants, climate, biodiversity, land use change, fresh water, ocean acidification, and others. And they're now saying that the majority of these planetary boundaries have been transgressed. Well, why is that so? Obviously, it's because of the activities of our species. It is us, mainly the high-consuming parts of the world, that are driving this dramatic change into a new geological or geophysical epoch called the Anthropocene, which some people dispute, but I don't think there's any doubt if you look at the science of the dramatic scope and scale of the changes that we're seeing. So
Andrew, you should be able to share now from what I can see in my settings.
Okay, fine. Let me see. Here we go. Yeah.
Okay.
Is that any good?
Yes. Perfect.
Okay, great. So let me put this on the display. Yeah. So this slide really tries to summarize this complex picture. On the left, you can see the underlying drivers, which are largely our consumption patterns. Obviously, population plays a role, but in general, you know, the damage is being done by those high-consuming parts of the population. So the top 10%, for example, are responsible for emitting about nearly 50% of greenhouse gases, something of that order. And the lowest, the poorest people, obviously of which there are many large numbers, but they are responsible for very small numbers of emissions. And depending, of course, then on the level of affluence, on the technologies available and the population size, that determines the level of greenhouse gas emissions and also many other changes as well. And you can see the Earth system changes summarized in the middle of the infographic. I won't read them all out. And then they lead to a whole range of different exposures, changes in exposures for human populations. Obviously, air quality, fresh water quality or access, food quality and quantity, of course, toxic exposures, infectious diseases of a whole range of different types, extreme weather events. And the impacts of these are modified by socioeconomic factors, obviously by your gender, age, where you're living, the infrastructure available, governance, wealth, and so on. And then these all have an effect on these endpoints, these outcomes, which are important for human health and are listed here on the right side. So you can see that these transgression of these planetary boundaries is having and will increasingly have a range of different impacts on human health. And this slide shows us how dramatically this picture has evolved over, less than 20 years. We're seeing dramatic escalation. And if you look at climate, for example, climate change has actually accelerated in the last decade. So we're actually deepening this crisis. it's not just an ecological crisis, it's a crisis for human civilization, of course. It's one in which there is enormous kind of opposition to tackling the root causes of the crisis, and we can come back to that later in the discussion. But obviously one of the reasons for that is that the drivers are those powerful forces that shape our consumption patterns. The fossil fuel industry, the big food industry, and so on. So there are very large economic interests at play. So what do we need to do about it? Well, we're going to discuss that now, but let me give kind of two aspects of this. One, of course, is better to understand what the threats are. We have to do that. And of course, we need more research to some extent to do that. We're seeing dramatic advances in methodology, which I can go into later. But we can now specifically attribute, we can quantify the health burdens from climate change. And we're beginning to develop more accurate projections going forward. But of course, there are many uncertainties and many variables you need to consider. But then you need to respond. And there are two types of response you can take. Excuse me. One is to adapt to the changes you can't prevent. And that means better early warning systems, more vaccines for climate-sensitive diseases, for example, better flood protection, forest protection, strengthening infrastructure, improving our resilience and our ability to thrive under different environmental conditions, and also changing agricultural practices to safeguard our food systems at the time of intense environmental change. But adaptation itself won't be sufficient. We can't adapt our way out of this crisis. We're heading towards probably 2.8, perhaps more, global average temperature increase by the latter part of the century. That's a global average. It's higher over land than over oceans. The Arctic is heating up faster than anywhere else. Europe, interestingly enough, is the fastest heating region, but everywhere is heating up. And it's not just heat, of course, it's also changing rainfall patterns, extreme storms, and so on. And this is being compounded with all these other planetary bounds, as I've talked about very briefly, which are compounding our exposures to toxic substances and damaging marine ecosystems and terrestrial ecosystems. So we have to mitigate, and in climate change terms, when we talk about mitigation, we mean cutting emissions. That's cutting emissions of CO2, which is the most important greenhouse gas, but there are many other greenhouse gases. Methane, which is a short-lived greenhouse gas, stays up in the atmosphere for 10 to 12 years. And the important thing about that is if you can cut methane, of course, you can rapidly slow climate change down, which we need to do because it's a climate emergency. So we need to mitigate, cut the range of these greenhouse gases. 75%, of course, comes from fossil fuel burning. And fossil fuel burning also causes air pollution, of course. And about 25% or so from land use change, most of that from the food system, some from deforestation. So the food system is a crucial part of all this. So we have to move towards mitigation, which means radically transforming our economy. And of course, that's why we're seeing so much opposition and pushback at the moment, even at a time when we are witnessing with our own eyes the extraordinary changes in the climate and the physical environment. So let me end on a note of optimism, because we're also talking about opportunities here. And what I would say is that many of the strategies that we need to put in place, both to adapt to these environmental changes, but also to mitigate them, will have great beneficial effects on human health in their own right. So, for example, if we phase out the burning of fossil fuels, we not only reduce the risk of dangerous climate change, we also reduce our exposures to air pollution. And we estimated recently that something like 5 million premature deaths a year could be attributed to the air pollution caused by the burning of fossil fuels, so specific to fossil fuel burning. Physical inactivity, major risk factor for the non-communicable diseases. You mentioned, Thomas, in your introduction. And the best way to tackle those, the public health, in a public health way, is, of course, through sustainable transport systems, which make it possible for people to walk, cycle, have physical activity, use public transport safely in their daily lives. And finally, the food system, which you know a great deal about, of course, Thomas, and that is, such a driver of ill health and environmental damage. And if you look at the Eat Lancet Commission report recently, for example, which is proposing that if we could move people towards what they call the planetary health diet, which is a plant-rich diet essentially, that potentially one could prevent around 15 million deaths a year mainly from these non-communicable diseases. So there are big benefits. So these are near-term benefits. Obviously, there are longer-term benefits from reducing the damage from dangerous climate change, some of these other environmental changes, but these are near-term benefits from, so often called co-benefits or ancillary benefits from action. So I'll stop there. So what I'll say is, in summary, this is an unprecedented challenge to humanity. Humanity has not faced this level of environmental change, rapidity, and throughout its history. But of course, there are also great opportunities for action. And the reason we're not seeing more movement, of course, is because these changes would involve the changes in the way that we live, which some people wouldn't welcome, but also they threaten major economic interests. And I'm sure we'll come back to that later in our discussion. So I'll stop there. Thank you.
Thanks a lot, Andrew. That's very good overview, and especially on the issue of climate change. And just one thing I wanted to pick up on is the sort of double injustice of climate change in the health context. On the one hand, that, like you said, the richest 10% have contributed most of the carbon emissions, and on the other hand, the people who are impacted most are, or have been until now, those who are least able to or at least wealthy, and in developing countries, but also poorer people in the developed countries. So there's this double injustice, and at the same time, from my own experience, I wanted to add that it's shifting a little bit in the sense that traditionally, I mean, a few decades ago, we would have thought that, well, in developing countries, you have a lot of communicable diseases, and in the West, we have these civilizational diseases that come with affluence. But I've seen that change dramatically in Southeast Asia, where I work. And they now have an epidemic of diabetes and heart disease, and the injustice kicks in again there because they don't have the medical facilities to survive these diseases. So people die from diabetes very quickly, and because they just cannot manage proper care. So that's one thing I wanted to say. And the other thing was climate change. And so obviously in England, where you live, and also throughout Europe, we've had this massive heat wave. I just wanted to ask you whether you had any comments about that, or what is it showing, or what impact does it have on the health system in the UK?
Well, we've known for many years, of course, that during heat extremes, and it's not just kind of heat waves, which are the kind of very extreme events, but also once you go above an optimum temperature, which varies depending on where you are in the world, then you have a rapid increase in death rates. I mean, obviously, also you get an increased death with cold as well, but heat deaths are going up very, very rapidly. It's a non-linear trend. So we are seeing increasing heat deaths that are being documented in many countries around the world. Increasingly, we can actually attribute a proportion of those deaths to say, well, these people wouldn't have died in the absence of human-induced climate change. And so, for example, we're just doing a work with our colleagues in Brazil at the moment, which suggests perhaps 50% of the heat-related deaths across Brazil could be attributed to human-induced climate change over recent decades. If you look at some of the recent trends in Europe, it's sometimes over 50% of those deaths could be attributed to human-induced climate change. So there's no doubt that climate change is having an effect on heat-related death, but it's not just, and of course we know that it's the elderly that are particularly at risk, but it isn't just elderly, also people with pre-existing diseases, sometimes children as well, depending on where they live and so on. But we also know that climate change is having an effect on other things like wildfires, for example. In parts of Europe, we're seeing increasing wildfire smoke, which is very highly toxic. We're seeing the spread of vectors, actually, even in Europe. It's very interesting. Where I'm staying at the moment in Galicia, in northwest Spain, there's an article in the local paper saying that the Asian tiger mosquito, has come to a small village just down the road from me. Now, the Asian tiger mosquito transmits dengue, chikungunya. So far, no local transmission. But once those mosquitoes bite someone,
that's very interesting. It kind of complements what I said earlier. You know, that
so it's literally a few kilometers down the road, the tiger mosquitoes are moving up. So it's happening. It's
the NCDs are going south, and some of the communicable diseases are
coming up.
Yeah,
exactly. The NCDs are really a big problem in much of Africa and Asia, as you said. And of course, many of the risk factors are rather similar: physical inactivity, ultra-processed foods, diet, or poor increasing penetration of unnutritious food, and air pollution, of course, big issue. In many countries, including in Asia.
Okay, well, thanks, Andrew, for now, and I'll move over to Nabil, if you'd like to unmute yourself, Nabil, and I'll ask you the same question. Just give us a bit of a background on what you've been doing and how that has shaped your views of global health and its risks.
Thank you, Thomas and Anna Maria. Good morning from London. It's sunny, bright, and a bit hot as well. And great to be on this podcast with three eminent professors. When I saw your names and profiles, I was ready with my notebook and pencil. I know that I'm going to learn a lot from all of you. Well, great opening question and a wonderful deep dive by Sir Andy Haynes on climate-induced health risks. You have asked about our profession, our perception of global health threats. In our case, I work for PATHS, which is a field player. We're quite broad spectrum, a term which is used for antibiotics these days. In our approach, we are fighting on almost 24 fronts. And with your permission, I will open the aperture a little bit from climate change and health. As from my perspective, there are 5 major threats. Not climate change is, of course, a big one. So starting with non-communicable diseases, you have alluded to it. Second one is infectious diseases. Third one, related to infectious diseases, is antimicrobial resistance. Fourth one will be conflicts and climate change. And I'm clubbing them together, and I'll talk about it in a little while. And fifth one is mental health, which is also becoming a big issue. So with your permission, let me talk a little bit about all 5 of them one by one. So non-communicable diseases, which are known as NCDs, such as cardiovascular diseases, diabetes, and cancers, are a huge risk. These conditions are slow-moving, but a bigger killer, as you have rightly said, Thomas, and a larger catastrophe. In 2025 alone, close to 43 million people died of NCDs. 43 million. So this number is more than the entire population of Canada. Let me give you another comparator here. This is more than the population of 13 sovereign countries in the Caribbean. So the worrying thing is that this burden is increasing. At number 2, I shall place infectious diseases. They used to be the biggest killers. They're spreading again, coming north, as observed. But thanks to science, antibiotics, and vaccines, they are not such a big threat anymore. Approximately 10 to 13 million people die from them each year. This number is equivalent to the population of 13 countries in the Pacific, from where you are based, Thomas. So I'm excluding Australia and PNG, 2 big countries, but everybody else, including New Zealand and Fiji, Tonga, Tuvalu, so 13 countries of the Pacific. Well, they still pose a significant threat to human lives. We have seen outbreaks of monkeypox, you may recall, measles here in the UK and in the USA, dengue, malaria, Marburg, And now I have 35 people of my team now working in DRC dealing with Ebola. Now, again, this is not a threat which is out there. It did not finish with the pandemic. It's very much alive and there. And let's not forget that we had a pandemic a few years ago, which took precious 7 million lives. Now, this is the official estimate. You have said 22 million. I fully agree with you. That's perhaps the exact number of people which died of it. And I must add that many of the deaths from infectious diseases are preventable. So this is the irony of it. Still, between 1.5 to 3 million people die every year from vaccine preventable diseases, mostly children, unfortunately. Number 3, I'll put antimicrobial resistance. 1 million deaths caused by it and close to 4.7 million per year associated with it. Global research on antimicrobial resistance predicts 39 million deaths directly attributable to AMR between 2025 and 2050. So in 25 years period. This means nearly 3 deaths per minute and a 70% increase in deaths from 2021, going very, very steep. Let me add that AMR is also a huge economic burden. I liked your framing when you said that you're talking about health and you're broadening it because you have a holistic view. So let me bring in the economic part here. The economic burden. It costs healthcare systems nearly $50 billion every year, which is more than the global health aid at its peak. It is estimated to double every, I think, in the next 25 years, reaching $100 billion. So no wonder AMR is also called a silent pandemic. And I'm of the view that we are not well prepared for AMR. We always talk about pandemic preparedness and response. It is spreading like wildfire. We remain dangerously unprepared. This is because common bacterial infections are becoming resistant to known medicines faster than the new drugs are developed. There is antibiotic overuse in developing countries and LMICs, and weak surveillance systems due to a lack of diagnostic tools. I'm talking about these things because I work in many of the Asian and African countries in this particular area. We're trying to strengthen the capacities of governments. And it's worth noting that simple surgeries and injuries could become life-threatening emergencies if antibiotics do not work. Let's not forget that. Thirdly, conflicts and climate change. Very comprehensive expose from Sir Andy Haynes. I look at it as a global risk, major threat. These are man-made disasters and underappreciated at times. They not only kill people, but also systematically dismantle health, food, agricultural, and water infrastructure, everything related to health. So I'm again broadening the aperture. You may recall that primary healthcare centers in the province of Sindh, Pakistan, were washed away by the floods in 2022, which was a bigger disaster than the floods itself. Climate disasters and armed conflicts disrupt routine immunization programs. My teams are working in Gaza, in Yemen, in Myanmar, in many of these war-torn countries. It's ironic. We call ourselves Homo sapiens. I'm sorry, I'm taking a little bit of digression here. The wise species, but are hell-bent on destroying each other and our environment. This comes from my heart, Conflicts have been on the rise and are at their highest level since World War II. The university in Sweden, the Uppsala Conflict Data Program, has documented 65 armed conflicts worldwide by the end of 2025. Unfortunately, we have added more in 2026. We are seeing new wars, greater disruption, and resulting migration. According to UNHCR, there are 42 million refugees and 118 million forcibly displaced people. This number is increasing. Together, these people make the 9th largest population in the world. People with no country, no life, no health, and no hope. These people are dying, have no access to healthcare, and are living in inhumane conditions. They face disease and death every day. Now, climate-induced health issues are another big risk. I'll not delve into it. I want to talk about some of the heat waves and its effects. I'm fully ready. You can see it's going to be 32 degrees Celsius here. Yesterday was the hottest day at 39.1. It was almost unimaginable. When I was sitting in the tube going to my office and coming back, terrible heat, which is taking its toll. New Delhi or Lahore, if you have ever visited there in winter, you can't breathe. And there is so much smog that you can't drive. It's unbelievable. Poor mental health, fifthly, and sadly, more than 1/10 of people worldwide live with mental health conditions. That means well over 800 million people, 1 in 10. So taken together, they will be the 3rd largest country in the world after India and China. This is a condition where disability is more painful than death. The World Drug Report estimates that nearly 300 million people use illicit drugs per year. And more than 40 million people worldwide have a serious drug use disorder. Disorders such as depression and anxiety alone cost the global economy an estimated $1 trillion each year. This is almost the GDP of Switzerland. $1 trillion. I can talk more. I'm very passionate about my subject, but I'll stop here. I just wanted to give you a broader overview from my perspective of out of 24 or so areas in which we work, what are the top 5? Thank you, Thomas, for the opportunity. Over to you.
Thank you, Nabil. That was very comprehensive, and I just had to hold my tongue because there's so many interconnections there that I would like to point out. I'll just restrict myself to a few. For example, you mentioned food systems as a foundation for good health, and this is a social, a political problem, because the food system we have is geared for profit now, not for feeding people, let alone feeding them with healthy food. And I can see, I've seen in Southeast Asia some of the changes to traditional food systems and how the NCDs exploded as a consequence of these changes. So there's that link. And then, of course, the link to climate change. You can, in Indonesia, for example, the new government just announced they are going to cut down 200 million hectares of primary rainforest in West Papua for food security reasons, which is supposed to support health. But, then again, if you look at who is actually getting that land, it's companies that produce basically sugar and oils, palm oil. So not exactly, a health conscious policy. Yeah. So there are all these connections, and we will explore them further. But I'd like to go straight on to Stefan. Stefan, if you would just give us a bit of an idea of how you come to the issue of global health risks from your own experience.
Yeah. First of all, thank you very much for having me in this chat, and I will skip my academic bio of the last 25 years by showing you some slides, and I would like to enter the debate, Thomas, through a slightly different angle. Give me 8-10 minutes about the debates I'm involved in, and then we can move on. How I look at it is that we have following the curriculum of Extra of WAS, we have systemic risks that to some extent translate into healthcare risks in one way or another. Andrew demonstrated and Nabil showed, and this translates in one way or another to finance and costs and productivity and economics. So my little intro is about the following. Because these systemic risks, whatever you take them, are all interconnected, you can show that within the insurance companies, within the healthcare sector, they cannot be pooled anymore. And this translates into something the debate calls the delta in healthcare costs. And this translates into the requirements of new financial engineering that can help to reduce the delta in healthcare costs and to basically reduce the interconnectivity and the pooling aspect. This translates basically from a formal aspect. I'm sorry to bother you being into finance and economics for the last 25 years in this field, into what we call the delta in healthcare costs. The delta in healthcare costs simply says that whatever we're doing, the sector in healthcare is always providing a higher increase than the average GDP. If we grow on a global level for 3%, let's say, the healthcare cost, the sector itself is growing by 4.2, 4.5%. And this is causing a constraint to the growth trajectory. And the same is true on a micro level. The healthcare cost, the marginal increase of corporate revenues are lower than the healthcare costs the company has to cover, right? If we take this idea of the healthcare cost delta, more or less with pretty good evidence as a starting point, I would like to know now to approach this question by three aspects. The first one is we have to find the right narrative. Let's zoom out for a minute, just for a minute, Thomas and all the people on the call. What do you think is the selection advantage of humans? It's not the opposition of the thumb. It's not thinking. It's not emotions. It's not working upright and standing upright. It is the capacity that we're able to tell each other stories and narratives we all believe in, right? And most of the stories of the last 20, 30 years around ecosystem restoration, about activism and environmental approaches basically got debunked over the last couple of months and years, right? The degrowth scenario, the population bomb scenario, even the CO2 load in the atmosphere with the high evidence got debunked because people don't follow. Species losses is another story. Huge evidence showed by Andrew and others, but we're not following that story. Could it be that we are barking up the wrong tree? Could it be that we have to put another story at the center of the entire transformational process required that avoids to depoliticize the entire program and to individualize the entire program? Do we need a more non-regret, more inclusive approach? And here suddenly, I think the healthcare sector is right at the center.
Stefan, could I just interrupt for a second? You say debunked, but I think what you mean is dismissed. Those narratives are not debunked in the sense of disproven, but dismissed despite all the evidence.
Yeah, there's huge evidence for all of that. I'm not even challenging that at all.
Just clarify,
We have all the evidence out there. We are repeating the evidence for 20 years, for 30 years, for 40 years, but nothing is changing. So could it be that the narrative we're telling about each other in how to transform our society into a non-fossil, more regenerative, more circular form of economy, the KPI of biodiversity loss, the KPI of CO2 in the atmosphere, highly evidenced, is the wrong KPI. Okay, that's my argument. So the first thing I would like to address is, if we shift and put the healthcare sector in the center of the focus, in all OECD countries and in major countries in the global south already, it is the largest single sector, right? All the other sectors, manufacturing, farming, etc., education, are second or third tier. And what's interesting about this largest single sector, in all societies, it has a specific market structure. They're all supply driven, all of them, without any exception. They have huge asymmetric information built in. They have a next to zero price elasticity. If you're sick, you have to buy the drug. There is no alternative for you. They create a massive positive spillover, and they basically, you can characterize them as quasi public good. We have huge data sets showing that the social return on investment in healthcare is by a factor 10, 50, 100 thousands higher than any other capital return. And fifthly, it causes a double insurance failure with regard to moral hazard. What we are facing here, if we put the healthcare sector in the center of the focus, is we are exposed in all healthcare sectors all over the world with the so-called sick, affordable, and alive bias. As long as you're sick, as long as you can afford the bill, and as long as you're still alive, you're fine, right? This is where the sector operates. These are the incentives for that sector. And these sectors are basically driven by 5 to 7 cost drivers throughout OECD countries and throughout major healthcare sectors all over the world. The first is aging, second, technology, the Baumol effect, huge impact of income disparity, probably one of the largest cost drivers in all healthcare sectors, and what Andrew showed and Nabil showed, the systemic eco-social threats we've just lined out. And what is interesting from a finance and healthcare perspective is that all tools we've been using so far have been failing to cover this delta in healthcare. Taxation schemas, fee-for-service, premium, and out-of-pocket payments, right? For all of that, we have a lot of evidence. For the largest single market and its flaws, for the sick, affordable, and alive bias, for the multiple cost drivers. And we also have a lot of evidence that all traditional financial tools we have been using so far were not able to address the delta in healthcare, right? This is my first intro before we start now addressing in a second round, maybe my second intro, where I'm trying to address the specific financial engineerings required in order to address interconnected systemic risks which cannot be pooled, causing a delta in healthcare costs where the traditional tools failed.
Okay. All right. So if I get to your argument up, just let me recapitulate a bit because it's quite complicated. I think what you're saying, the delta in healthcare is the excess growth in healthcare costs relative to economic growth, corporate earnings, and so on. So there's the health sector is exploding. And, you know, it occurred to me, why is this? Is it because of labor costs? Is it because of, you know, the cost of production of pharmaceuticals? I don't think so. I don't think that healthcare workers are overpaid generally, or that it's become that much more expensive to produce pharmaceuticals. I think it's more that, and correct me if I'm wrong, is it because we have higher expectations and also higher need due to aging populations? What are the...
I mean, this is, Thomas, this is exactly the point you have to discuss with healthcare economics. There's 5 to 7 cost drivers built in the incentive structure of each healthcare system on the planet. One is aging. If you expand the life expectancy by 10 to 12 years, you automatically cause more costs at some point in some subgroups of the population. The second is technology R&D, right? the next drug will enter the market, period. And it will cost money. In biologicals, we are talking about 20, 30, 50,000 additional costs per capita to treat a disease, right? The third one is the Baumol effect. Well described, really well described. A lot of evidence demonstrating that the costs are increasing in the healthcare sector, not because of productivity gains, but because of productivity gains in other sectors like manufacturing, IT, etc., in order to match the salaries in the healthcare sector. So if a nurse doesn't get paid the same than an average industrial worker, they basically leave the healthcare sector and go into manufacturing. The fourth one, where the Marmot report from London demonstrated very accurately, is income inequality. The simple fact that we are increasing the gap between the rich and the poor, regardless to which society do you look at. Piketty data, Pickett and Cathwood's data, huge data set. It doesn't matter which society you look at. The larger the gap, the more expensive the costs are by living in these societies.
Okay, right. I think it clarifies it, Stefan. Thank you for now. So clearly a lot of people are going to be priced out of healthcare, at least top level healthcare, although what we've come to expect. And also I think, it's a big discussion these days about, distinguishing between a lifespan and health span. And we're having a lot more lifespan, but not necessarily a lot more healthy years. And those unhealthy years are extremely costly. Okay, now I'm going to have a bit of a quick turnaround between the three of you and ask you the same question or engage you in a discussion. And one of the things that we hear a lot about is about what in the aftermath of the COVID pandemic, obviously a large number of people died. There was a lot of lessons learned. One would hope we have learned a lot. Clearly, there has been some advances in understanding how to deal with pandemics in a global context, but how well are we prepared for the next one, and how close might the next one be? Here in Australia at the moment, we are the last continent actually to be invaded by H5N1, which is avian influenza, and as we know, it spreads to mammals, particularly marine mammals, but also humans. What are the risks? So where do you see the risks for the next pandemic? How prepared are we? What should we do? And where are we actually going backwards because of cuts to aid in health? So start with you, Andrew. You might be able to say something about that.
Yeah, before I briefly address that question, I just wanted to quickly respond to something Stefan said, because I think one dimension that's been completely omitted is the commercial determinants of health. And also the fact we can't equate health with healthcare. The fact is that health is a result, not just of the healthcare system, but also the drivers of ill health, the socioeconomic and environmental drivers. And at the moment, we have an economy in which you can make a lot of money by making people sicker, by selling them, ultra-processed food, tobacco, whatever, alcohol, and you don't pay the cost of that. So why not do it? You can make a lot of money out of it. So unless you internalize the costs of these commercially damaging activities, you're never going to be able to keep pace. So I don't disagree with what Stefan said, but I think you can't leave out the commercial determinants. And frankly, a lot of the ecological crisis we're confronting at the moment is driven by commercial factors, because you can make more money out of it, and no one is telling you not to, and no one is taxing you, and no one is regulating you. And in fact, our whole economy is saying, let's deregulate. Of course, we need to take out harmful bureaucracy, but we shouldn't be deregulating these essential issues. So I want to just say that. And then in terms of the pandemics, well, of course, we could have one at any time. There was a very interesting paper from a colleague in the States, Colin Carlson, showing that a combination of land use change and climate change drives species closer together, but also because forests are declining, of course, so species are forced closer together. There's greater transmission of infection from wild animals to domestic animals, from domestic animals to humans. So you're getting this encroachment of population growth onto what was previously natural systems. And that isn't bound to increase the risk of these kind of zoonotic diseases, some of which will be pandemic, not all, of course, but some will be pandemic. So I think it's inevitable we'll get more pandemics when nobody can actually say, but we need to be constantly on alert. And one of the big lessons from COVID, I think, was the relative success of the vaccine response, despite all the negativity and the disinformation. But it was very interesting to see how much of the resources was transferred from the public sector to the private sector. Now, where did that original research come from on mRNA? It was funded by us, the taxpayers. And yet when it came to it, our governments gave vast billions and billions of dollars to private sector companies to develop the technology. Well, shouldn't they have also taxed them to pay for the original research that drove that innovation? So we haven't got the balance right between the public investment that we make as taxpayers and the private profits. And that's one of the things, of course, that's driving inequalities, and it's driving disparities in expenditure, and it's undermining the public sector. So we need to address that. The other thing I would say as a general point is that I think we neglected in COVID to look at some of the really important public health interventions. So, for example, they never did proper studies of what it would take to put air purifiers in schools. Did we really need to keep millions of kids out of school? I'm not sure. I doubt it, frankly. Yeah. We never, we could have done some cluster trials, and within a few months, you'd have known. Do air purifiers in schools reduce transmission? And if they do, we could have kept a lot of those kids in school. So some of these simple public health interventions were never trialed, probably because they didn't have advocates at the table. There wasn't big money in it. And the other thing I would say is primary care. I'm not aware of any country really which developed a coordinated primary care response. I had a very great Kenyan PhD student who was studying the role of community health workers in addressing COVID in Kenya. And she showed that in one district where she herself actually trained the health workers, gave them masks, gave them protective equipment, gave them pulse oximeters, trained them in basic monitoring of signs. Not only did it reduce the death rate quite substantially compared with neighboring districts, it also improved the capacity of these community health workers. They were lay people who were being trained to do these basic public health tasks. So we never really mobilized, I think, primary care response. So primary care, public health, and getting the balance between resourcing of public and private, how we spend the resources and support innovation, I think are all crucial issues. Thank you.
Yeah, it's interesting also, I think, to think about, again, the inequality factors, reflecting back on COVID, for example, the fact that in some of the developing countries, because of the younger population, the mortality rate was actually lower from COVID itself, whereas in the West, it was higher because we have older societies. But again, there it was the poorest who were suffering from obesity and other complicating factors that had the highest mortality rate. And most of all, from a food perspective, there's the fact that probably more people died from hunger, from additional hunger to the supply disruption in the food system than from the virus itself. So these are all things that should be carefully considered. But what have we actually done? And I think, Nabil, you might be in a good position to answer this, in terms of monitoring, early warning systems. What concerns me is, with the cuts in aid, how are those monitoring systems looking? Are they going backwards? Do you have any insight into this?
No, absolutely. pandemic preparedness and response and vaccines is close to 50% of our work in PATH. And I have a good news and a bad news. Let me start first, if I may, from your question, which is what have we learned from the pandemic? I think this is something very close to my heart. I'll talk about our practice, but a little bit more philosophical, because this is more of a mindset question. It's a question which is bigger than the health sector. And this reminds me of Will and Ariel Durant, the great writers, philosophers of the 20th century. And let me quote a sentence from one of their books, The Lessons of History. This is more like a general lesson. And they write, the only thing we learn from history is that we learn nothing from history. It's very unfortunate, it's cynical, but it's true. Now, coming back to your question, the first part, which is what we should have learned, I want to quickly make 5 points before going to monitoring and surveillance systems. Number 1, we're on top of the food chain, but we are not invincible. Despite so much progress in science, technology, innovation, an invisible pathogen can still kill us and in millions. No matter how strong your health system and preparedness are, we are still vulnerable. We are still vulnerable if we are not careful. Secondly, we must realize, as Sir Andy Haynes is saying, we must realize that all life is one. Our health and well-being are intimately connected to other forms of life. Plants, as our food, who give us oxygen, not only food, animals, and planet Earth, which is the source of all life. The source of pandemic is generally an infectious disease. And most emerging infections, more than 60%, Sir Andy Haynes would know the exact number, are zoonotic in nature. That means they're moving from animals to humans. Thirdly, pathogens do not have borders. They're not bound by race, religion, or region. They will move seamlessly, spread from one person to the other, and kill at their will. They would not spare you if you come from a powerful Western country or poorer South. And I want us to recall where most of the pandemic deaths were, in the most prepared and the most advanced country. 1.2 million people died. The lesson for us is that we must cooperate and collaborate to deal with such global health threats. Fourthly, we should invest in public health infrastructure. I can't agree more, which has been said. Primary healthcare, strengthen supply chains. We live in a fragmented world. The reality is much bigger than the health sector, which is geopolitics right now, which is the deeply divided world. We must value frontline workers. We must combat misinformation, all these vaccine hesitancy. It started from that one. And there are new kinds of truths which are emerging right now. And focus on protecting the most vulnerable groups. Fifthly and lastly, we should strengthen international preparedness and response mechanisms. I was a multilateral diplomat for 15 years, and I've been thick in those negotiations with the UN system, with WHO. Although, the watered down version of the pandemic treaty was adopted in May 2025 last year, the international cooperation system in global health has become much weaker in the last couple of years. One would think that we have gone the other way. It's more fragmented now since the end of the pandemic. It lacks trust, it lacks investment, it lacks capacity for global response. Somehow we have convinced ourselves that pandemics come after 100 years, the next one will be after 100 years, so we are okay. Right? Ebola is there. As I told you, 35 people from my team are there. And this goes back to your question. We are helping strengthen the monitoring system, diagnostics, lab capacities, And that's what we have been trying to do at the country level.
Mm.
But as a social enterprise, this is beyond our capacity, that we cannot convince the big powers or big players to come
Mm.
together
Mm.
and for the sake of humanity, for the sake of global health, to collaborate more. I'll stop here.
Okay, thank you, Nabil. That's great work you're doing there, and it'd be good to have more money behind those efforts. And it looks like the reverse is the case. That the funding has dropped, and that's could lead over to Stefan. And Stefan, you wanted to say a bit more about the financing side of addressing, the shortfall.
Yeah.
In the
Let
health
me
system.
get back first to the pandemic stuff, because
Yeah.
at that time I was already a medical director, and we had to cope with this on a day-to-day, case-to-case base. And as Nabil very nicely put it, we learn from history that we don't learn from history, and history repeats itself as long as we don't challenge and solve the problems involved in it. And what I learned in the pandemics is, not in all, but in a lot of cases, we have the knowledge. We know we do the predictive coding, we do the vaccination, we do the separation, we do the public health strengthening, we should do the primary care strengthening, balancing out the commercial with the public interest, the private with the collective interest, et cetera, et cetera. I was up in a hearing in Berlin a couple of months ago, being asked exactly the same question you've just addressed us. The probability for the next pandemic this was a Chatham rule-based debate, so I can talk about the content, but not about who spoke about the content, is almost 100%. The probability for the next pandemic. I'm sorry, maybe you don't want to hear that thing, but the risk is almost 100%, whether you like it or not. So now let's step back. Okay, if we as a world community are exposed to a systemic risk that costs 10 million to die over mortality, that caused a productivity gap and shortfall of 14 trillion on top of it, right? Due to all the
You
restrictions.
still have a sovereign debt crisis because of it across the world.
Exactly.
Yeah.
The question then arises, okay, look, if there is a risk out there with almost 100% certainty, shouldn't we step back for a minute and say, look, we got to do this different next time? And Nabil and Andrew mentioned it already. It's about prevention. It's about upfront loading the WHO, which is chronically underfunded. It's all about money. It's all about, not all, but it's mainly about the finance. How can we finance a systemic risk, which is interconnected? It's one health. It's affecting all of us, independent whether you're rich or poor, whether you're north or south, whatever educational level you have, you're just going to be hit in one way or another, directly or indirectly. We are confronted with the systemic toxic healthcare pandemic cascade in one way or another, right? And what I learned from this pandemic is, if we don't get the finance right, the incentives right, it will be just as harmful and as deathly for all of us than 3-4 years ago when all that happened in the first place. So we're always discussing around, okay, we have to do public health. Yes, we have to do public health. Of course, we have to do prevention. Yes, we have to do prevention. But the point is, where does this extra money comes from in a realistic way in order to fund all that? This is the question we are dealing also at the WAS in this working group on the Tower of Finance, saying we have extra costs, we have externalities, we have spillovers, accumulated spillovers in the healthcare sectors and others. How can we address them? Is taxation, internalization of costs, pay for performance, etc. The only way to do it And I think it's not. Yeah.
And again, I would point to inequality as one of the determining factors there, because the reason we can't internalize those costs, the reason we cannot take action on many of these issues is because it doesn't, you know, the corporate interests that are opposed to that. And inequality means that basically a lot of our democratic systems have been captivated by those.
Let me maybe I can show you again a couple of slides if that's okay.
Go ahead.
5 minutes? Is 5 minutes okay?
Sure.
Let me see how to do this properly. Okay. Sorry. I think if you look at this entire debate from a pure financial and economic perspective, and I agree, Andrew, the commercial side of healthcare costs has been underutilized and under mentioned so far. I think we need a two-tier approach. The first tier approach, which can be called a subsidiary budgeting. Each healthcare sector, you remember in the first place, I mentioned all the flaws and the very nature of the healthcare sector, supply-driven, net zero elasticity, blah, blah, blah. It requires a subsidiary budgeting, meaning you apply a specific budget in order to do your job on a country level, right? A regional budget or a sectorial budget. And you predefine the KPIs in order to achieve them. So many children saved, so many non-communicable diseases treated, so many depressions saved, etc. And then thirdly, you leave for the healthcare providers to provide this delivery freely, whether they do inpatients or outpatients, whether they give a drug or do medication, whether they do outpatients treatment or they do only lifestyle changes, leave it with them. They know better. This is why it's called subsidiary budgeting. This is the first tier. And here, taxation kicks in. Taxation can basically partly internalize the costs the commercial sector is exerting on healthcare. But there's a second one. And the second tier is because the healthcare delta is far higher than through covered by a subsidiary budgeting, we need regulators, central banks to kick in. We need what we call a conditioned green QE, meaning at some point in the near future, which had happened already in the past, by the way, through the pandemics, nobody talked about it. And it happened already in 2008 as a rescue package for the Greek crisis, the Euro crisis. Sooner or later, we're going to end up having additional liquidity, conditioned liquidity for the healthcare sector, WHO, but not only WHO, also domestic level, which is running through, from a monetary perspective, called CBDC, central bank digital currencies and its associated swap lines. We did, over the last couple of years, a lot of research on that. We just published actually 2 months ago in Nature a paper on that. And they're all DLT, distributive ledger blockchain associated. And then you have two components. You have a subsidiary budgeting, which increases the efficiency of the system. And you have conditioned green QE, which basically increase the resilience. And with these two approaches, you can basically also address what Andrew showed with the adaptation and mitigation aspect, right? We can build dams and vaccines and restore ecosystems, but at the same time, we have to make the system more resilient at the same time. And these two components require a two-tier approach where efficiency and resilience both kick in order to address the healthcare delta.
Stefan, just for clarification, of course, QE is quantitative easing, and that was used, as you said, to address some of the costs of dealing with the COVID pandemic and also global financial crisis and the euro crisis in 2012. But at what level do you think this should happen, at a national level or international? Who is the right
very
agency
good.
or jurisdiction there?
Super. Thomas, give me an hour on the jurisdiction, but I have to, on the EU level, it's Brussels and Frankfurt, ECB and EU Commission. And the legislation, if I have more time, I can show you it's working within the given infrastructure. By the way, until the end of this year, the central bank digital currency approach with their swap lines are going to go online anyway for Europe. The Chinese have been doing this already since years, and the Americans are stepping out since half a year, but we're doing it. We have basically the financial infrastructure available already for beta testing exactly our approach, right?
The other thing I wanted to ask you just quickly, I don't want to stop your flow, but for our viewers, I think a lot of viewers would think, what is that going to do to public debt? How does it, how does it differ from, say, bonds? Public debt is usually in the form of bonds and treasuries and things like that.
Yeah, but very good. This is one of the first questions that arise, and the second question that arises is what is its impact on the CPI, on the consumer price index, et cetera, et cetera. Look at the specific monetary instruments the regulators and central bankers of the largest 7-8 central banks on the planet used in order to cope with the money crunch associated with the pandemics. They did not issue sovereign debt. They did not issue increasing taxation. What they did, to put it very frankly, they went in the cellar and printed money and provided that money for WHO, for countries in Europe to deal with these rising costs. On a balance sheet level, what's happening is that central banks are increasing their balance sheet. Yes, they're increasing their balance sheets. If you look at the costs for NCD, for example, or for infectious diseases or AMR, etc., they increase the cost, let's say, of 1.2 to 1.5 trillion. The balance sheet is extended. But at the same time, this money is conditioned with the blockchain technology to just solve the problems associated to it. And if you take this argument one step further, the next argument from mainstream economists is, this is very expensive, it's going to increase the CPI. And I say, no, it's not going to increase the CPI. If we don't do anything, inaction is causing the increase of CPI. Meaning we know from public health research over the last 25 years that any preventive measure is by a factor 10, 100 to 1,000, depending on the project, cheaper than inaction and repair and fix afterwards.
Yeah.
Roughly.
Okay. All right. Well, it's a complicated matter, and it gets into the real sort of the details of the financial system. Really a different topic, but let's just say that a lot could be done by using alternative financial instruments to fund both human health and planetary health, because you call it green quantitative easing. And very important, it has to be targeted to areas where it will reap great rewards. Like I said, the return on investment is very high. Andrew and Nabil, did you want to comment on that? What do you see while we're on the topic of finance? Do you have any thoughts to add to that?
I'm certainly no expert in the financial system. But what I would say is we need to be very aware of the kind of political economy of all this. And so any attempt to reform the system fundamentally will meet with extraordinary resistance from those who are benefiting from the current dysfunctional system. So in proposing any solution, First of all, we need to be scientists, we need to be experimental, so we need to evaluate what impact that proposal is actually having when as it's implemented. Secondly, we need to be aware that it will probably be weaponized against us, as we're seeing at the moment, so that the arguments will be distorted. There will be vast amounts of mis and disinformation, and we shouldn't be naive. So we should understand that there are big political, economic barriers to this, and they need to be addressed with as much rigor and as much energy as the actual development of the policies themselves. The secondly, I think terminology is very important. I wouldn't use the term green QE because I think green has become linked to particular political positions. And what's really important to re-establish, this is about humanity. This is about the flourishing and survival of our species. Some people don't like it because they say it's anthropocentric. I've had that criticism. And I say, well, the fact is we are an anthropocentric species and we're the ones that are doing all the damage. So if you want to appeal to us as a species, you know, you have to make an argument that we're going to benefit in some way. And you can appeal abstractly to the preservation of nature and species. But in our culture, because we're not indigenous people have different cultures in many cases, but those arguments are not flying for whatever reason.
Wonderful.
So
Andrew, do you have an idea? Do you have an idea what other term to use?
Well, I like the term planetary health or One Health, but I wouldn't separate human and planetary health. We often have this debate. Say, oh, human and planetary health. I say no. The whole point is that our health is inseparable from the health of the planet. We live on a small planet. I mean, okay, Elon Musk wants to leave it, and good riddance to him. Good luck, you know, let him go. But most of us are going to stay on the planet, and so we need to make sure that the planet still can support the life of our descendants, because it won't be just us; it'll be our descendants. And I think that probably does bring us back more to the indigenous perspective that we have lost through our apparent civilization. We've lost this important insights about how interdependent we are on the natural systems that are kind of underpin our civilization. So we need a bit of humility. We need to rediscover some of those concepts. But we also need to act with courage and expect that we will be attacked. And it's no point in, you know, you have to anticipate. It's a bit like the next pandemic. You know, it's going to happen.
Very good. Well,
and
very,
you know,
very
it's going to be a pandemic of misinformation. You come up with a great solution, you're going to be attacked.
I agree. Wonderful. Thank you very much for your experience and background, especially for this issue. What's about anthropocentric QE?
Yeah.
Look, if I spoke to some of my ex-patients and I said, oh, you know, I'm working on anthropocentric QE, they say, what? Doctor, what? What I would say to them, you know, what we're trying to do here is we're trying to sustain our little planet in a way which will be supportive of your health and the health of your descendants, your loved ones. And that requires some big changes, you know, in the way society is run, the way in which we're all going to live.
Wonderful.
And I think we have to really reduce that argument to the kind of argument people understand. We can use these technical arguments with, you know, the 0.1%, the elite who understand.
I agree.
I use them in quotes because the elite are often themselves deluded. So
wonderful. Wonderful.
they think
Thank
they're
you
the
very
elite.
much.
So, you know, we have to call them the elite.
That's very good.
I want to make one other point, actually, which Nabil really, I'm so glad he introduced it, because I think we're underestimating the role of militarism. And what we're seeing at the moment is 2.7 trillion spent on weapons, which will bring us no security. They'll just increase insecurity. We have well over 12,000. You know, we are perfectly capable of destroying the whole of civilization through nuclear war. That could happen anytime, just like the pandemic can happen anytime. So could nuclear war. We have thousands of weapons on hair trigger alert. It only takes one miscalculation for those to be set off. So we haven't talked about that. Very important. But I would say the economic burdens of militarism are with us right now, as Nabil has said. And also it's directly and indirectly undermining health. And also remember, the military is responsible for about 5% of greenhouse gas emissions, just as the healthcare system is responsible for.
Yes, it's all interconnected. And I think here we go again about the lessons of history not learned, because it's an ancient truth that we should know that famine and pandemics and war tend to go together.
Go together.
That's the other thing. Bill, did you want to chip in on the finance issue before I ask Anna to see whether she has any topic she would like to raise?
No, no, absolutely. I think this discussion is becoming super interesting. I'm loving it. And I'll try to make it a little bit even more interesting by asking a provocative question to two professors. I'm learning a lot. And I did PhD as well. I didn't become an academic. I'm not as wise or experienced. I went to the field. So I'm just trying to bring two perspectives here. One is logic on which we work through research, narrative, storytelling, why it's not, and then you look at the reality, right? So we have been telling the world, okay, we are going to hell. Climate change is there, it's knocking at our doors. It's in my room right now. I'm sweating. I know that it was 39.1 away. We have been telling the world for a long time. And I feel very comfortable with finance, went to a business school. I was looking at, wonderful arguments made by Stefan. There are $147 trillion available in the world of finance right now. Out of that, 50 billion were going to global health. Now 50 billion as ODA. 50 billion is 0.00003% of this $147 trillion. They have gone down. Yeah. As Andrew said, now military spending has been going up. So there's a V-type curve where development aid has been nosediving, and then defense spending has been skyrocketing. So it's a V-type curve which is emerging, unfortunately, right? Why we are not getting there? We call ourselves Homo sapiens. So it's all boils down to perhaps interests, political interests. And this reminds me of my own story. One before the last WHA, I was talking to one of the health ministers at the margins of WHA from East Asia, very close to Australia. And I said, look, we have done this wonderful work in Vietnam on healthy hearts, on diabetes, on advocacy, on screening, and some regulation. Can we experiment it in your country? He looked at me and he said, look, you don't want to, you hate me. You don't want me to be here next time. Because, and I have to look up, you're telling me that I ask my populations not to eat that much sugar and stuff. So there is their political interest that they have to watch their interests. Political interests other than corporate interest and financial interests. $2 trillion. Everybody is becoming mad about AI. We're already burning in health. You want to, take the little bit of water or electricity or clean air from me by investing a bit too much. We are for AI, we work in AI, but this mad rush which starts, it's unbelievable. The herd behavior which we are seeing in the world. I don't know. And this is my question to three professors, and that is, tell me, how do we deal with it?
Yeah. Can I shortly answer, Thomas?
Sure. Yeah.
Okay. First, Nabil, this is exactly the point you're raising. It is the mindset, right? If we have the wrong mindset, it doesn't work. Why did we fail my question I'm asking in my circles is, why did we fail? We're telling each other the wrong story. We use the wrong KPIs. A species lost somewhere in the world is not mobilizing 8 billion people. And a CO2 load, to understand, you need a PhD in physics, okay, despite all the evidence. So this is my argument, saying if we start putting the healthcare sector in the center of our narrative, right? Despite all the evidence of the CO2 and blah, 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 we have a good chance, because I'm telling you, because I'm a shrink, I'm a psychiatrist, I'm involved into doing narratives the whole day, saying this, if you have a good chance for behavioral shift, for being emotionally affected, whether you're left or right, it doesn't matter. Second question, with regard to the 150 trillion private equities out there, actually the number is even higher. I know them because I'm involved into this debate for years. It's over 200 trillion. At the end of the day, the question is, this money is never be deployed for healthcare because the risks are too high. The CEOs of these companies are not bad people. They're not unethical or immoral. They simply going to tell you in private calls, we have enough money. That's not the question. The question is the risk associated to it is too high. And here again, our approach of WAS and the Tower of Finance initiative kicks in. If we were prepared to create, for example, for ABS, asset-backed securities or state guarantees, first loss tranches, specific financial engineerings that cover the first loss tranche, suddenly the private sector will jump over the hurdle and kicks in. Okay, and here we are in a completely different world than the world we are discussing with conventional economists.
Yeah, that's right. Yeah, I can think of many examples to illustrate it. But Anna, we're running a little bit out of time, and we're having a wonderful time. It's 90 minutes never passed as quickly. But I wanted to give Anna a chance to ask a question to you, starting with Andrew again.
Yeah, so I really liked our discussion. I'm really happy that we speak about mindset. I'm really happy that Nabil raised also the quote that we didn't learn nothing from the past and we repeat it. As I see from my perspective and from my heart, is that we are living in a human disconnection pandemic. So to find solution, I know that there are trillions money on the market, and why we don't put the health and the humanity and the nature at the core, and why let's say we put trillions in data center and AI. My question is, as a human sapiens, can we move to the next potential of humanity? Because we can find solution, we can put money in different action, and maybe we end in the same place. So is AI a possible solution to help us, or it's repeated problem invention, let's say, as we invent the bomb atomic, we invent everything. So this is my question. There is with AI a question: deserve the money that we take from us, from our health, from our water system, from the food, to give to AI or not? Or is really a problem of human disconnection totally, and we are not aware? Collectively, we are not aware what's happening, because as you said, also rich people die even they have money. So the problem is not the money, it's our human nature. Can raise a little bit, can we explore our human potential at the next level, and if AI can be a solution or not? This is my question to everyone.
Again, just to give some perspective on the scale of this, the biggest five tech giants are planning to invest $1 trillion over the next year alone. Absolutely, lots of money available there for doing this. What does it do to the health sector? Andrew, do you want to start?
Well, going on to the question of AI, I mean, of course, it's very much a mixed blessing, isn't it? I mean, we use it in collaboration with colleagues, for example, at PIC, at Potsdam Institute of Climate Research, Climate Impact Research, to analyze the increasing amount of literature, for example. You can't do that manually. You have to use AI to kind of summarize these things. Of course, you have to check it, you have to validate it. But it can be a very important tool. But the problem is, at the moment, is we're seeing, I think, a trivialization of the use of AI. So it's being used, who knows exactly how it's being used in aggregate. It's probably being used, isn't it, to maximize profits in the short term. I think the way in which it's being used at the moment is not sustainable. And we need to come up with more codes of practice. But unfortunately, codes of practice and regulation are not fashionable at the moment, because we're supposed to allow deregulation such that the financial sector can benefit from the fruits of its investments. So I think we need to fundamentally rethink that. I think AI can, in some circumstances, be supportive and beneficial of some of the changes we'd like to see. It's not an answer, it's not a panacea. and it could equally have very many adverse effects. I think that's also going to be true in the arena of militarism and war, where we could see some of the risks of war, including possibly nuclear war, increased by AI in ways that we don't fully understand right now. So I think it is fraught with danger, but that's not to say that there aren't positive aspects as well. That it can be used for human well-being, for planetary health, but I don't see that as being a driving force at the moment, sadly. So I'm very cautious. And just in terms of how we leave the situation with people, I think it's very important. One of the problems we've had at the moment is we've just emphasized the negative and the fact that we're all going to hell and things are going very bad. And we know that that doesn't actually cause people to change in the right direction. In fact, if anything, it makes them retreat and say, okay, well, things are terrible. I'll just focus on my family. I'll just buy a new car or whatever it is. Actually, you need to give people hope, not naive optimism, but you need to also say that, yeah, we can do things better. It is possible to live within planetary boundaries. It's possible to live well. And this is the kind of life that you could lead. And I think we failed in communicating a positive narrative about the kind of life that people could lead, with vastly lower levels of consumption, better mental and physical health. And it seems to me that it's that positive message that we need to communicate much more effectively than we have in the past.
Yeah, very good.
Stefan, do you want to talk a little bit about what it's looking like in hospitals? I mean, the rollout of AI and
exactly. There's a two-tier thing. On a micro level, on a corporate level, this is going to happen. From ICU to psychotherapy, from predictive coding to EEG monitoring, it's going to happen. It's going to improve the efficiency of case-to-case treatment in one way or another, for sure. And it's going to happen. On a macro level, Anna, the question is, however, different because we have to be aware that the so-called technology fix, and that's what it is a flaw in itself. I'm not sure whether we can really solve most of humankind's problems by simply implementing a technology. And this is where our approach kicks in again, saying, a new technology without a different financial structure and architecture that incentivizes it in the way we want it will always create negative spillovers for all of us. So I would be careful about the technology fix narrative as the only one. However, on a micro level, I think we see a lot of benefits on a case-to-case patient care.
Okay. And Nabil?
Thank you, Thomas. This is my most favorite question as an engineer. And I have been into this AI business for quite some, maybe 20 years before people started thinking about it and talking about it. And it's a double-edged sword from my perspective, as with any other technology, as Anna was mentioning. And I agree with Andy that we should look at it more from the opportunity perspective. Thomas, you started today's webinar by saying that you believe in polycrisis, right? Which I fully understand. But in this particular case, AI is a poly opportunity also. I know the dangers which it has, but let's also go to the poly opportunity. We run AI health systems hackathons from Harvard University and MIT every year. I'm part of that. From the Commonwealth side, I sit on there, and UN's AI Regulatory Council, as well as World Economic Forum. We are very mindful of what kind of regulatory policy issues which need to be discussed and debated at the highest possible level. But in a fragmented world, whatever is possible, we are trying to hit the, unfortunately, lowest common denominator to make things forward. 4 things from my side, and this comes from my personal experience because I started the AI work in Bath, and I had the honor of starting the climate change and health work. And again, Sir Andy Haynes was super helpful. I recall, Sir Andy, I requested you to come and speak to my board because they were not very convinced. So thank you. That was the tipping point in the organization that we started that work in climate change and health. Now, AI is another story. 4 years ago, I started talking about it. We are the very few global health organizations who appointed the first chief AI officer. And we have an AI strategy also. There are four points which I wanted to make. Number one, at the system level, it has kind of accelerated drug discovery. And it's also speeding up clinical trials for vaccines development. Some our core work, which we do in Path, together with the Gates Foundation. Now, it's highly effective in imaging technologies such as radiology, X-rays, MRI, and we are working on AI projects with Wellcome Trust here in the UK, which we are integrating climate and health data for better predictive modeling and preparedness. This is a huge project in 3 countries, which we have started together with the Wellcome Trust. So that's the kind of system level improvements which can come if we go in the right direction. So at the professional level, it's helping doctors, clinicians. Through a Gates Foundation grant, we are developing a clinical decision support system across 3 African countries. We have done trials, we have published 6 papers already, more are coming, and we are hoping that one day that will be used actually in the US for the marginalized communities. And it's helping doctors. I'm talking about now AI once again, not only in the clinical decision support system, but also taking notes and saving time. There's so much of administrative burden. So this could be more like a virtual assistant. It's helping frontline workers to make better diagnostics and decisions. That's another project of mine together with Google in 5 countries in Africa where we are working. So at the systems level, at the professional level, then at the organizational level. In Path, it is reducing costs for us. We are going full throttle ahead. We are automating several functions and processes in accounting, finance, legal, and HR. We have a Path knowledge agent. We are training actually our colleagues because we have 50 years of history. There are thousands of projects which are there. So what have we learned from them? So what happens is, there's a call for proposals from a donor. Everybody rushes and starts, scrambling and saying, okay, does someone know? Have you ever worked in malaria before or polio eradication? It's all there. So we have consolidated it. You can go to that knowledge bot. You can ask, and this is an internal thing. It will tell you, look, we have done green vaccines. It surprised me because I thought that I have started climate change and health work. It proved me wrong by saying that, look, the project was actually in Tunisia for Gavi. We did green supply chains in 1997. I didn't know that, right? So a lot of good work, using AI, which is helping us a lot. And at the personal level, it helps everyone track data and get fitness guidance with a caveat that, in the past, people used to have Dr. Google. Now they have Chat GPT specialist. This can misguide you. And for common people, I think this is also causing a lot of problems also because they believe in some of those things. These are not experts. These models can tell lies. They can sell your data. There could be security breaches. We are firmly of the opinion that humans should be in full control, and these systems should be just helping us making better decisions and creating efficiencies. I'll stop here. This is my favorite topic. As Stefan said, he can talk about 1 hour. I'm happy to talk about 1 hour about this one.
I think just to link what Stefan said, we really can't stop it. It's not going to stop. Okay, there's no way it's going to stop. If for no other reason than the military competition between the US and China, which is driving this race to turning it into a race. Though we had Jerome Klen in a podcast not long ago. He's the head of the AI committee advising the UN General Assembly, and apparently there are talks about it between the G2, as they like to call themselves now. The other thing is, like Nabil said, if it's unstoppable, we may as well get on the good side of AI and make the best use of it, because it is costly. It has an impact on energy, on water, and so on. So and also it's a drain on the financial resources. So we better make good use of it. And regulation, of course, we have an article in this month's extra newsletter, which you can subscribe to on the website, and about the legal guardrails for AI in the health sector specifically. and also on another article on transdisciplinarity in that context in dealing with AI. So anyway, we've had a long conversation. We could easily continue, and maybe we will after some time. And I want to thank you for your contributions. I've learned a lot, and I think our viewers will have as well. And yes, I think it's a fast-moving area, and I mean, people sometimes ask us, why do we have to keep talking about existential risks? Don't we know all about, climate change yet? No, it's evolving. It's constantly changing. The issues are changing. The speed of climate change is changing, and so on and so forth. So all these risks are they're constantly evolving. And it's not a negative thing to look at risk, because life is risk, and life is existing with risk, not closing your eyes to it or getting upset about it. It's dealing with it in a competent manner. That is what life is all about. So I think we all always also looking at the ways of managing risk in a constructive manner. Would you like to have any closing words? Maybe Stefan, would you like to?
Okay. First of all, I would like to thank you for the debate we had and the invitation to your webinar. I would like to leave my comment with a question to the audience and to you. The stuff I'm struggling with at the moment is, as Andrew said, we need adaptive measures and mitigating measures. What is the best ratio between the two with regard to finance? We are not going to answer this question right now, but I leave it with the audience who listen to that. In case they have any ideas, I am happy to follow up separate to this webinar. And many thanks for all the insight I could gain through Andrew and Nabil and Anna and Thomas. Looking forward for future debates.
Thank you. That's a difficult question indeed. We can't approach that. We probably need both, but the proportion.
Yeah, we need both. Yeah, the question is the ratio. Yeah.
Andrew, did you?
Well, I'd just like to echo thanks really for inviting me to participate in this really very intense and I think fruitful discussion. Obviously, we've raised a lot of issues. We can't solve all these problems. I would just sort of end by saying that we should be quite cautious about solutions that pit one solution against another. Say, how much do we spend on this solution and that solution? I think increasingly what we need to think about, what are the integrated strategies that will help us to address multiple issues at the same time? In my view, increasingly, government should be looking for policies that both reduce risk, but also deliver multiple benefits across different sectors. And climate mitigation is a good example of that, but there would be others as well. And so in terms of adaptation mitigation, I would say let's search for strategies that develop synergies between adaptation and mitigation, so we can invest in a holistic way that will address both of these problems, both timescales, the very near term and the longer term. And it seems to me that that is one of the new frontiers in policymaking, is how do we identify these systems approaches that will allow us to integrate, in this case, both adaptation and mitigation, and confer benefits and minimize, of course, the trade-offs. There are often trade-offs, but you have to minimize those. Thank you.
I think that's very key, Andrew. This delivery of the political class on a systems level would do a great deal to restore faith in democracy also, and curb popularism. But Nabil, final words.
Thank you, Thomas. I learned, I contributed, interacted for great humans. I think these are the joys of lifetime well spent. When I will look back at my experience, in terms of my message, I would say let's not lose hope. We can continue to live in our own silos and echo chambers, and we can choose that way, or we can choose a better way to swim in the sea of solutions, where or systemic solutions, I would say. I will choose the second one, and my request will be choose wisely. Thank you.
Thank you very much, Nabil. And with that, we will close the webinar. Thank you all, and we'll love to have you back for another time, maybe in a few months' time or so. Thank you very much. Okay, Verini, we can stop recording.